Laboratory features. Next, I have made a list of tests for the diagnosis of this condition. These include acute phase reactants, specifically ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein, along with rheumatoid factor, RF. As I explained earlier, rheumatoid factor is an IgM antibody directed against the Fc portion of IgG. This is a common microbiology-based question: which antibody is RF? The answer is an IgM antibody attached to the Fc segment of an IgG antibody. Because RF can be biologically false positive in 5% of the normal population, it serves only as a screening tool. It can also be negative in a substantial number of patients. Therefore, for a definitive diagnosis, the primary test to perform is the anticyclic citrullinated peptide, anti-CCP, antibody test. Imaging modalities. To assess joint damage, for example, if a patient complains of pain or damage in the wrist or MCP joints, what imaging tests can we order? In the past, we primarily used X-rays, but X-rays often detect changes fairly late in the disease process. For early identification of joint involvement, we can utilize MRI or ultrasound, in addition to a standard X-ray. However, if asked which imaging modality is preferred for rheumatoid arthritis today, especially from an orthopedic perspective, MRI is the recommended choice because it can identify early changes effectively. Synovial fluid aspiration. This is primarily for academic reasons. In real clinical practice, we do not routinely perform synovial fluid aspiration for RA. However, if we were to aspirate the fluid, we would observe inflammatory findings. In RA, the synovial fluid typically contains between 5,000 to 50,000 neutrophils. When you see that number, you might initially think of septic arthritis. However, in septic arthritis, the neutrophil count is much higher, often reaching into the hundreds of thousands. Thus, a count of 5,000 to 50,000 indicates inflammatory synovial fluid, not an infection. Radiological findings in the foot. Regarding X-rays of the foot in atypical presentations, for example, pain in the small joints, specifically the MTPs, where would you see the radiological changes? In acute gout, changes are typically seen in the first MTP joint. In rheumatoid arthritis, however, you must remember to look at the lateral aspect of the fifth MTP joint. While the fifth MTP is often targeted first, other joints can also be involved. To reiterate the distinction, in gouty arthritis, there is usually a clear trigger. This could be binge drinking, alcohol, or medications like antitubercular drugs, for example, pyrazinamide, that impair uric acid excretion, causing a spike in the joint space. It could also be the use of thiazide diuretics in a hypertensive patient, which increase uric acid levels. These triggers will be provided in a clinical question, along with involvement of the first MTP joint. In contrast, RA involves multiple small joints of the foot, with radiological findings most prominent on the lateral aspect of the fifth MTP. Treatment of rheumatoid arthritis. First-line therapy. Disease-modifying antirheumatic drug we use is methotrexate, MTX. It promotes adenosine release and exerts an anti-inflammatory action. Painkillers are only adjunctive therapy, and the chronic use of steroids is discouraged. Triple therapy. Triple therapy has been frequently tested in recent exams. Traditionally, you might associate triple therapy with H. pylori eradication, using a PPI like pantoprazole alongside two antibiotics like clarithromycin and amoxicillin. However, in the context of rheumatoid arthritis, triple therapy refers to the combination of methotrexate, sulfasalazine, a drug also used in inflammatory bowel disease, hydroxychloroquine. Caution with hydroxychloroquine. It can cause retinal toxicity, necessitating dose adjustments. It can also cause QT prolongation, so it must be prescribed with care, especially in patients with cardiovascular issues, keeping in mind that the leading cause of death in RA patients is ischemic heart disease. Step-up therapy, biologic DMARDs. If triple therapy does not achieve remission, we initiate a step-up approach. We discontinue sulfasalazine and hydroxychloroquine, maintain methotrexate, and add a biologic agent. The biologic DMARDs we can use are remembered by the mnemonic ACEIG. A. Adalimumab. C. Certolizumab. E. Etanercept. I. Infliximab, a TNF-alpha antagonist also used in inflammatory bowel disease and ankylosing spondylitis. G. Golimumab. Another biologic is tocilizumab, an interleukin-6, IL-6, inhibitor. IL-6 plays a significant role in the pathogenesis of RA, justifying its use here. Targeted synthetic DMARDs, TSDMARDs. If biologics are not used, targeted synthetic DMARDs, primarily JAK inhibitors, can be utilized. Tofacitinib, a JAK1 and JAK3 inhibitor. Baricitinib, a JAK1 and JAK2 inhibitor. Caution with JAK inhibitors, recent clinical trials have highlighted significant side effects. Increased cardiovascular mortality, a critical concern since ischemic heart disease is already the leading cause of death in RA patients. Increased risk of malignancy. These drugs are used alongside biologic DMARDs as step-up therapy if initial triple therapy fails. Determining remission. How do we know a patient is in remission? Remission criteria are generally based on achieving scores of 1 or less across several metrics. Tender joint count less than or equal to 1. Swollen joint count less than or equal to 1. CRP values less than or equal to 1 mg per deciliter. Patient global assessment, based on a questionnaire, less than or equal to 1. Ultimately, the goal is to substantially reduce the patient's disability, so she can hold her toothbrush, regain her grip strength, and perform household chores, and to prevent crippling hand deformities using the medications discussed. If you found today's breakdown helpful, please subscribe to the channel to catch the next lesson.